Now I'll request Dr. Sachin to talk about glaucoma in pregnancy.
So I start by thanking the AIOS and Dr. Tanuj sir for the opportunity. So just as an extension, we'll just see the drugs that we need to be careful of in this subset of population. What we need to know that about this topic is that nowadays we have an older age of at conception, rising infertility and incidence of around 2 to 3% of glaucoma in pregnant women above the age of 40. Although the percentage in ages less than that is minuscule, the consequences of a miscalculation can result in lifelong morbidity of child, complicating the quality of life years. So the categories of patients that we may face in this are the glaucoma patients wanting pregnancy, glaucoma patients presenting with pregnancy, glaucoma with relentless progression in pregnancy, and glaucoma in breastfeeding. So the risk profile of each class of drugs actually changes with time of gestation and breastfeeding, so not to miss the transition is very important. So the major diagnoses that we deal with are usually congenital and developmental glaucomas, juvenile glaucomas, secondary ones with steroid, pigmentary, GRA associated, uveitic and post-pediatric cataract surgery, and also some primary glaucomas considering the older subset of population. The denominators that we consider during this treatment are the stage of pregnancy, stage of disease, that is glaucomatous damage and the rate of change, specific risk factors and allergies, FDA classification and safety profile of the drugs basis published reports and animal studies. And remember that no medicine in this is the best medicine and the least medicine is the second best. So why this is a special situation is that you have the pregnant patients have a lower IOP than the general population, contributed by the lower episcleral venous pressure. But what you have to remember is that majority of these changes start at the end of the first trimester and fade out after weeks of childbirth. So the major part of the first trimester is not covered by this physiological pressure lowering. Intrapartum pressure changes are not very significant to be of any consequence, and whereas most of these glaucomas that present in this age group usually are very high pressure glaucomas, the physiological drop might not be of any consequence. Now as far as pregnancy in glaucoma patients are concerned, now this is a topic that prevents clinical trials because of ethical considerations. So all the information that is available to us are available on reports case series. The reports of IOP changes are mixed, with decrease in the second trimester being the commonest and variable fluctuations with some increases in the third trimester that have been noted. General IOP reduction early on is usual and maximum documented is around 24% in the late second and early third trimester. So active surveillance for all glaucoma with very high IOP is very advisable because these are the patients who will progress. So the most important subset of patients I would say is the glaucoma patients wanting pregnancy. So if the patient is already on the radar, this is the time to act because major preventive actions can be taken and plans can be put in place. Counseling and planning for future pregnancy is imperative at opportunistic or regular visits. Medications can be minimized, adjusted as per the triage, FDA recommendations to reduce the fetal adverse events basis current knowledge. Trial of laser procedures, performance of anticipated surgeries can be evaluated and appropriate counseling can be done for this subset of patients, preventing major handicaps. Now, when the patient presents with pregnancy is the major challenge, and our options are usually a multidisciplinary approach between the radiologist, obstetrician and glaucoma specialist. The medications, laser and surgery are the options as we all know and have seen. The considerations are stage of pregnancy, stage of glaucoma and risk-benefit ratio. Needless to say that malformation scans when the patients presents to you in early first trimester are very, very important for the further counseling of such patients. Now the medications are classified by the FDA into A and X category, where A is safe and X is teratogenic. Unfortunately, none of the glaucoma medications fall into the A category. Some fall into B, that is like brimonidine, B for brimonidine, and others fall into category C and mitomycin into X. So here, although brimonidine is safe, aproclonidine is still categorized in category C, and it is brimonidine is labeled as safe in all stages of pregnancy, but not in breastfeeding. It can cause apnea and respiratory depression in infant. That is where the transition takes place, and you have to be careful in case the patient is on brimonidine pregnancy. As far as the beta blockers are concerned, a category C drug, it can cause IUGRs, fetal bradycardia, and low Apgars with systemic beta blockade. And you have to use with abundant caution in pregnancy, especially in low doses of 0.25%, avoiding the first trimester and the peripartum period. Punctal occlusion has to be demonstrated and occlusion has to be stressed for such patients to minimize the chances of a problem. Caution and monitoring in breastfeeding is also essential. As far as carbonic anhydrase inhibitors are concerned, oral and topical, the category C drugs, major trials which have been reported have not shown too many side effects of carbonic anhydrase inhibitors except in the first trimester, and also some fetal limb anomalies in animal studies. So the general guideline is to avoid them in the first trimester and use with caution in the later stages. High doses can be avoided peripartum to prevent electrolyte imbalances in the child. They are deemed safe by American Association of Pediatrics in the breastfeeding period though. So they can be used safely in the breastfeeding period with due caution. As far as rho kinase inhibitors and pilocarpine is concerned, they can be used with caution in second trimester and in breastfeeding, but adequate data is lacking in these two drugs and not too many publications are available to support the same. As far as prostaglandin analogs are concerned, this comes last in the list because contrary to the normal belief of starting prostaglandin analogs first, it being a uterine stimulant, it should be avoided in any stage of pregnancy. However, reports of uneventful usage are available and discussion with patient and obstetrician are prudent, but definitely you will not be using them in the third trimester near term or in the first trimester. They're likely to be safe in breastfeeding period due to the pharmacokinetics and faster elimination from the circulation. Lasers in pregnancy can be considered for mild to moderate but stable disease. SLT treatment is to be considered in open angle cases to reduce the drug exposure in the first trimester. Subset of beneficiary population is limited in most cases, as we all know that most of the diagnosis will be either congenital, juvenile or inflammatory glaucomas which have poor results with SLT and also have very high pressures. Small proportion of primary open angle glaucomas would benefit for the limited period of its effect. Peripheral iridotomy, iridoplasty would deliver similar effects in pregnancy as in non-pregnant women in angle closure disease. As far as surgery is concerned, if there is relentless progression of glaucoma in pregnancy, that is one option that you may have to consider in cases where the progression is quite rapid because of the limited safe armamentarium that is available. The challenges, however, would be with anesthesia. General anesthesia would be difficult. Positioning of the patient with a gravid uterus causing cable compression and syncopal attacks. Contraindication to mitomycin C because it is a X category drug. Limited data on mixed efficacy. GAD can be considered, not too many studies available. Limited antibiotic coverage post-operatively because macrolides are only deemed to be safe in pregnancy. And local anesthesia, definitely with lidocaine would be the safest. With small dose, maybe peribulbar or local infiltration at the site would be ideal. Bupivacaine has to be avoided because it can cause fetal bradycardia and should not be used in pregnant women undergoing surgery. So pointers are multidisciplinary approach with obstetrician, gynecologist and radiologist is mandatory. Risk-benefit ratio is the center point, irrational and avoidable medications to be withheld, progression to be closely monitored, informed choices and discussion with stakeholders, especially presenting with pregnancy on medications. It's mandatory to demonstrate eye closure and occlusion has to be stressed. SLT can be used in selected cases if diagnosed at appropriate times. So surgery without antimetabolites is relatively safer under lidocaine or local anesthesia, and it should be resorted in relentless progression and inadequate IOP control. And breastfeeding has its own rules and medication choice, so transition from pregnancy to breastfeeding should be well known. Thank you for your patient hearing.
Thanks, Dr. Sachin, for the nice information about pregnancy and glaucoma.